National Echo, Chris, and you're going to be talking today about sleep disorders. So, without further ado, over to you.
Great. Thanks very much, David. And it's always a pleasure to be back at Echo and have a good time. But the pressure's on today because I have to be scintillating. So I'll do my best. But it's great to see a lot of familiar faces and our CCSMH friends. And thanks. Okay, great. So I am a geriatric psychiatrist at Baycrest. I have some academic areas of interest in sleep disorders as well as optimal medication use and deprescribing, which overlaps a lot here. And I work primarily with the community outreach team. So I support largely folks with cognitive impairment as well. So we're going to talk about sleep, big picture, but of course, we're going to zero in on some of those issues most relevant and unique to folks with dementia. All right. I don't have any disclosures to share in our usual disclosures from the program. Okay, so I'm going to start with a bit of an overview about normal and abnormal sleep in older adults. Then we'll talk about some unique factors in dementia. We'll talk about assessing sleep problems in older adults, including with dementia, as well as talk about the treatments, both pharmacologic and non-pharmacologic. All right, so thinking broadly about the main forces that drive sleep and why do we sleep, when we sleep, there's really three main things. There's the homeostatic force, of course, which just basically is the idea that the longer you're awake, the sleepier you become, the more likely you are to fall asleep. There's also what we call the circadian factors or kind of the daily routines and rhythms. The timekeeper for that actually lives in the hypothalamus in the brain. And the Germans coined a term called Zeitgebers. So these are the factors throughout the day when we eat, when we exercise, exposure to light, all of these things that help to set that clock in the hypothalamus. And then, of course, there exist many different neurotransmitters that can affect sleep. Probably too much to get into one by one, although we'll talk about some of them when we come to the part on the medications and why certain medications either promote sleep or cause sleep problems. And what I'm showing here is a hypnogram. So this looks at across the horizontal axis hours of sleep. So this is time basically throughout the night. Looking at the top, younger adults, and at the bottom, older adults. So this isn't yet getting into the dementia group. We'll come to that in a couple of slides. But just in general, when you compare the sleep and the stages of sleep from younger to older adults, and just to review the stages of sleep. So in the hypnogram at the top, we have the awake state. Below that, we have REM sleep, which physiologically is actually most similar to the awake state. And then we have stages one, two, three, and four. In the new nomenclature, this is a bit outdated because you'll hear spoken about stages N1, N2, and N3, where stages three and four, which are often described as slow wave sleep, they're actually quite similar. So they've been grouped together in what's now called stage N3 of sleep. Okay, so we have the awake state, REM sleep, and then, if you will, N1, N2, and N3. And some of the differences we see from younger to older adults. One thing is if you added up the total amount of sleep in older adults, you see the total sleep time is less in older adults. You'll also see more fragmented sleep, where more times people actually come out of sleep into the awake state. While many of these are actually so brief, we may not even register consciously, but there is more awakenings happening. Put those together, in older adults, you have reduced what's called sleep efficiency, and I'll come back to that. Sleep efficiency is the idea of the amount of time somebody is in bed, what percentage of that or how many hours are they actually sleeping. So it's a ratio. We also see in older adults less of the slow wave sleep, so less three and four, and less REM sleep. And not pictured here, but there is, as is often thought in older adults, a phase advance. So that means earlier to bed, earlier waking up, as well as older adults are more likely to nap. Naps in and of themselves are not necessarily a problem unless they're interfering with sleep at night. And, prolonged naps often do that. So just sleep problems in older adults, they're common. About half of older adults in the community report problems with their sleep. When you move into long-term care setting, the numbers go up. And when you move into like acute care hospital, even up beyond that. There actually is a bit of a gender disparity where females are more likely to experience and report sleep problems than males. If you dig down into the stats a little bit more, we'll see people with lower income and lower education actually experience and report more sleep problems. The consequences, of course, are many. Sleep problems in and of themselves lead to worse quality of life. Of course, they can be a risk factor for a number of different medical, cognitive, psychiatric conditions. We'll come to that. Of course, they're often a source of caregiver stress and a reason for need for institutional placement. And sleep problems in and of themselves are an independent risk factor for mortality as well in older adults. Now, if we look at sleep problems in dementia, I'll say a few things to start. They're common, and I'm going to talk about what the dysomnias and the parasomnias are in a moment. The people with dementia are more likely to experience insomnia. They're also quite likely to experience circadian rhythm sleep disorders. So this is the idea that people are asleep and awake at sort of atypical times. They don't have a traditional block of sleep when during what we might think of as the nighttime, and they're not necessarily awake all the daytime. So they may be have mixed patterns of sleeping and wakefulness both day and night. Also, sleep apnea is more common in older adults with dementias. The parasomnias, which I'll come to, are abnormal events in sleep. So a classic example of this is REM behavior disorder in people with synucleinopathies. So these are people with Parkinson's disease or Lewy body disease.
And emerge. Stroke
Uh,
alert now
uh,
and emerge. Stroke alert now and emerge.
mute, please. Thank you. So about 90% of people with synucleinopathies experience REM behavior disorder. Of course, in people with dementia, depending on their living environment, they may be in an institutional setting that we'll come to that create some challenges with sleep. Of course, some of the dementia medications, so acetylcholinesterase inhibitors, one common side effect can be insomnia. It can happen with memantine too, albeit much less likely. And some people actually likely some sedation with memantine. Sleep and dementia are related in a number of ways. So there's actually some evidence that insomnia, for example, is a risk factor for dementia. There was a recent study out of Harvard that showed that older adults 65 plus who slept 5 hours or less per night were twice as likely to go on to develop a dementia. Untreated sleep apnea is an independent risk factor for dementia. Of course, sleep problems can be a prodrome, and a good example of that would be that REM behavior disorder and the synucleinopathies that can often present many years before the onset of the cognitive and functional decline. Of course, sleep problems can be a symptom of dementia, and they can be a prognostic marker too. So the last reference on here, the Kang study, showed that older adults with Alzheimer's disease who had sleep problems at baseline were more likely to show beta amyloid deposition in their brains when followed over time. So it can affect the course. Uh, okay. So how do we assess sleep problems? Really not much difference here between people with dementia and without. You're still going to go through the same process. You're going to look at the amount of sleep people are getting and assess the quantity as well as the subjective quality of sleep. And of course, any problems arising from poor sleep. I meet people all the time that say, I sleep 5 or 6 hours a night, and that must be a problem, and I need to sleep more. But seemingly they're actually not impaired functionally distressed by it, and it actually may not be a clinical problem. Obviously, thinking about causes, so some environmental and causes, circadian causes, so what sort of activities are happening and when during the day. Assessing for the effects of substances, including alcohol and drugs, as well as prescribed medications that can affect sleep. Thinking about a whole host of medical conditions that can affect sleep. Some of the most common being nocturia, right? Awakening at night to pee, pain issues, cardiac diseases, right? Like heart failure, as well as acid reflux. Of course, just about all psychiatric conditions can present with sleep problems. This the primary sleep disorders that I'll come to in a second. If people are able to, or if you have some assistance, even in people with dementia, you may be able to get a sleep diary. So actually trying to track when people are sleeping and possibly other activities during the day. But of course, the DOS scale, direct observation scale, which can often be requested, even if for a period of a few days, to try to get a sense of people's routines and when they're sleeping, can be very helpful. And the polysomnogram, so a sleep study, not for everybody with sleep problems, but just, of course, if we're trying to rule in or rule out certain conditions, like we're trying to confirm sleep apnea, for example, we'll want to check if there is a REM behavior disorder, things of that nature. And I'm briefly just going to walk through some of what the dysomnias and the parasomnias are, according to the DSM-5. And again, the dysomnias are difficulties with getting to sleep or staying asleep. Parasomnias can be thought of as abnormal events or movements happening during the night. So in terms of the dysomnias, just briefly, there is a condition called insomnia disorder. So this is if you've ruled out all these secondary causes, people who are having problems with either subjective or objective sleep at least 3 nights a week for at least 3 months would have meet the criteria for insomnia disorder. It often presents early in life and at least early in in adult years and tends to be a pretty chronic condition. These folks do quite well with CBT for insomnia, and we'll talk about that. I've spoken a little bit about circadian rhythm disorders and scheduling activities during the day, and sometimes melatonin at night can be helpful. Narcolepsy is a rare condition, 1 or 2 per 1,000 with that tetrad of symptoms, but typified by sleep attacks and a few other things. Obstructive sleep apnea, of course, quite common, treatable with CPAP machines. Central sleep apnea is related, but a bit less common. Is conditions sleep-related hypoventilation, and the last one, hypersomnolence disorder. It's an interesting state where people are actually sleeping 9 hours plus per night, but have excessive sleepiness during the day, and you can actually measure it objectively as well with variants of some sleep studies. Look at something called a multiple sleep latency test, and you'll actually see people falling to sleep unusually quick despite having a fulsome period of sleep. Now moving to the parasomnia, so abnormal events, REM behavior disorder. We talked about it a little bit with some of the treatments here being clonazepam, often one of the few first-line indications for clonazepam. Melatonin also has some evidence. Dopamine agonists beyond that. Restless leg syndrome, quite one of the most common um, sleep disorders in about 7% of older adults, commonly caused by antidepressants. So keep that in mind for folks who are on antidepressants, as well as low iron, kidney disease, uremia are common causes. Here, the dopamine agonists are first-line treatment. And the bottom two, I'm not going to get into. They're more so conditions of childhood and actually rarely extend into older adults. We think about treatment of insomnia. Of course, we want to first address any of the secondary environmental causes. Come back to that in a second. Then thinking about non-pharmacologic approaches first, CBTI, I'll tell you what that is and how it can be modified for people with dementia. Plus or minus a role, hopefully short term, of the sleep aids, and we'll talk about a few ideas to keep in mind there. Interestingly, people, certainly patients, maybe clinicians too, believe that the sleep medicines just are more effective and more helpful. And there's actually been some head-to-head studies that have found CBT for insomnia actually more efficacious than sleep aids when pinned head-to-head. And these aren't cherry-picked studies. So these are the few studies that have actually been done looking at sort of comparisons between meds and behavioral approaches. Okay, so what is CBT for insomnia? So these are the core ingredients. The first piece, I think we're probably all doing, in many of our encounters. So talking about sleep hygiene, we'll review that briefly. Stimulus control. The idea here, I'll come back to it, but we wanted to make sure that when people are, they're only sleeping when they're in bed. Okay, so if you're not sleeping, you don't want to be in the bed. I'll come back to that. Sleep restriction, we'll talk a little bit about this. And there are some cognitive pieces too. And there have been some innovative models. So CBTI works when delivered in group format online. Interestingly, you can do a lot, even a single session of CBTI teaching the skills can be quite powerful. Okay, so sleep hygiene, fairly probably nothing surprising here. Just want to make sure that we're setting the environment to the extent possible, light, noise, temperature for sleep. You want to try to keep a fixed schedule day after day with the same bedtimes and wake up times, and ideally much of the same daily routines. Of course, trying to remove the effects of substances. You don't want to eat too much before bed, but actually you don't want to go to bed on an empty stomach either because hypoglycemia can actually trigger some physiologically an wakeful response during the night. So eating low glycemic foods, having a snack in the evening, nuts, cheese. Exercise is good, but not before bed, of course, watching fluid intake. Of course, trying to avoid the screens, especially in bed. All right. Keep rolling. So just a bit more about some of these CBTI approaches. So I mentioned with stimulus control, this is all about uh, conditioning. This is all about training our body and our mind to associate the bed with sleep. And then the more we can do that, the more people are going to fall asleep when they're in bed. So what you want to do is you want to make sure someone doesn't go to bed until they're sleepy. And if they're in bed and not sleeping, to actually try to leave the bed, ideally leave the bedroom altogether, but certainly in places like long-term care, that can be difficult. They only live in one room setups. But if you see somebody is, awake, and often it's the 15-minute rule, not sleeping, try to get them out if possible. Try not to do other things as much as possible, like eating in bed, watching TV from bed, and certainly no screens. Sleep restriction, one of the most powerful elements. The idea here is that, especially for people who have low sleep efficiency, meaning a lot of time spent in bed, only a fraction of that sleeping, you want to actually try to restrict or limit the amount of time in bed. And we can do that by pushing back the bedtime. And what's going to happen is when you push back the bedtime, people are going to be sleepier when they do get into bed. They're more likely to fall asleep quicker and sleep more of the time that they're in bed. And the goal here is to get sleep efficiency over 85%. Okay. So if sleep efficiency is less than 85%, that would be an indication to potentially restrict. Okay. For these behavioral approaches I just mentioned, in theory, if they can be supported either through staff, however, I know that resources are often very limited, or more likely if there's private caregivers, you can actually, work on these behavioral approaches in people with dementia. Okay. The final piece, cognitive therapy, is just trying to identify and correct any distorted beliefs about sleep that may be leading to worry. A good example of that is a common belief that if somebody came out of a night of poor sleep, that they're more likely to sleep poorly the next night. But I mentioned that, of course, with the homeostatic drive, if people slept poorly the night before, so long as they can stay awake, they're more likely to sleep better the next night, actually. And suffice to say, there's a lot of evidence for CBTI in older adults and some positive reviews and systematic reviews with evidence that the kind of multi-components, CBTI, and in particular, the sleep restriction being an important piece. Okay, and some other non-pharmacologic approaches, there is some evidence for Tai Chi and exercise, mindfulness approaches, as well as music. Okay, before bed. So it's kind of the soft melodic music, okay? And so probably for most people, not rock music and things of that nature. And what about the evidence in long-term care? Well, unfortunately, despite some, continuing to try to look into this area, there's not too much. There's very little evidence. That which is there tends to be small studies, some of it mixed. But where there is some evidence, that little bit that's there in the areas of possibly some bright light therapy, one study showed music, I mentioned, daytime activity, as well as trying to regulate the amount of light, light during the day, lights off at night, and noise. So there's some signals for people in the long-term care setting that these addressing these pieces may be helpful, but these studies have limitations. So, because the evidence is really not comprehensive or persuasive yet, what might be feasible for our older adults in the long-term care setting with dementia? Some of this might be a bit repetitive, but just wanted to bring it home. Setting the environment, okay, light, noise, temperature, trying to manage those health triggers to the extent possible, stopping any problematic medications, reducing disruptions. So the idea of patient-centered rounding, right, and timing of medication dispensing. So where possible, trying to limit, interrupting waking up older adults, especially during the night. Some daytime activities that may be feasible in the long-term care setting and may help. Activities. So, and in particular, maybe mindfulness, maybe exercise, social activities, and music. And you can certainly adapt some of the CBTI approaches to try to limit the naps, schedule bedtime and wake up time, trying to get people out of bed during the day or even at night if they're not sleeping, and potentially, if you have capacity, to do a little bit of the sleep restriction as well. And in terms of, so switching over in the last little bit, talking about sleep aids and some rational approaches to sleep aids. And again, first thing to keep in mind is these are after we've tried some of the non-pharm approaches. And if there needs to be a sleeping pill, ideally in the short term, less than 4 weeks. Many medications that can develop a tolerance, it seems to be around that month plus, where more of the tolerance is likely to set in. Obviously, lowest effective dose, as needed doses as opposed to daily doses, again, to reduce the risk of tolerance. In here, avoiding long half-life agents, the main reason being to reduce the risk of accumulation over time and reduce the risk of drowsiness, falls the next day. And obviously trying to limit any concurrent other substances, alcohol, medications like opioids that could contribute to sedation and falls. Okay. Just want to check how are we doing for time. Where are we at? I've got a few more minutes. Okay.
Yeah, we're good. We're good.
Good. All right. So I want to say a few things for just the different classes of hypnotics and touch on where the evidence lies currently and some pearls for older adults. So we'll walk through, these are kind of some of the main classes when you think of what are sleep aids. Some of these are heterogeneous classes. We'll talk about that. So a little bit about the benzos. There's lots of guidance that benzodiazepine, and often group benzodiazepine receptor agonists, so the benzodiazepines and the Z drugs, they have similar properties, similar side effect profiles. So they can often, I think it's reasonable to think of them together. CCSMH under Dr. David Kahn's leadership, there's obviously guidelines around optimal use of benzos, use disorders, preventing benzo use disorders. But know that there is some evidence of efficacy that they can help sleep, albeit in the short term. There really isn't good evidence that they have any long-term benefits. And of course, there are concerns about side effects, dependency. Interestingly, there's been some studies that have shown that they're more likely to harm than to have a beneficial effect, right? So the number needed to treat for a positive effect is actually larger than the number needed to cause harm for benzos in older adults. And the Z drugs, similarly, they have some evidence for short-term efficacy, and they might be slightly better in terms of less disruption of the sleep architecture, meaning less disruption to slow wave and REM sleep, which benzos can do, but they do carry much of the same risks of physical cognitive side effects as the benzos. So Z drugs being the medicines like zopiclone, zolpidem, those types. All right, now sedating antidepressants. So there's been some good news that over the last 2 decades, there's less antipsychotics and less benzos being used in long-term care. What's increased in that same time? It's the sedating antidepressants that have gone up. Many of them are used, at least in part, or sometimes fully for sleep. Trazodone, there are some small studies that show maybe effective in older adults, but still there are concerns about side effects, thinking about orthostasis, rare side effect unique to this medication. Mirtazapine, there's been no good evidence that it helps older adults with sleep who are not depressed and anxious, although certainly if there are untreated mood anxiety disorders, something to consider. Now, tricyclic antidepressants also, we know there's risks, the cardiac risks. Many can be quite anticholinergic. There's some evidence doxepine is actually recommended in some of the guidelines. It's a tricyclic antidepressant, albeit the doses here are quite low. The American Academy of Sleep Medicine suggests 6 milligrams or less. It seems that most Canadian pharmacies, you can't even get that dose. It's 10 milligrams and up. So just thinking low dose doxepine. But all of these antidepressants do carry the risk of QTC prolongation and therefore some potential cardiac issues that should be considered. All right. And melatonin related, again, this is a bit heterogeneous. There is some evidence for melatonin in older adults. A lot of the research here is out of the UK, and there's a bit more evidence for the slow release melatonin. There's actually a medication in the UK that's approved for insomnia in older adults called Circadin, actually, and it's a slow release melatonin. So it's something certainly to consider. Seems to be pretty well tolerated. Occasionally nightmares, occasionally drowsiness the next day. Not that common from what I've seen. It's also a second line treatment for REM behavior disorder, and there's a little bit of evidence that it may reduce risk of delirium for people at high risk. Ramelteon, a melatonin agonist, there's some evidence, but we don't have it yet in Canada. So I won't say anything more on that. And just a few others. So lemborexant or Dayvigo, it's approved now. Interestingly, the monograph says it's not studied in older adults, but there is some studies for a sibling drug called suvorexant or Belsomra for insomnia in older adults. Okay. Magnesium does have one positive RCT, tends to be pretty well tolerated over the counter. Antipsychotics, of course side effects. I'm sure you guys have talked to them, spoken to them in the recent sessions as well. There are the ones that are often used for sleep are often quite anticholinergic as well. And speaking of anticholinergics, so the antihistamines are in many of the over-the-counter sleep aids, but of course, with a high anticholinergic burden, that speaks to risk of delirium. Valerium comes up as well. It's a GABA modulator with limited evidence, safety data, and given its mechanism on GABA, there may be some concerns when used with those benzo receptor agonists. I suspect there might be some questions or thoughts about cannabis. Really scant evidence purely for sleep, especially when you add to that older adults. The studies that I've seen tend to be more observational. The outcomes seem to be mixed. And for those people where there is some benefit of cannabis, there does seem to be some tolerance quickly in some studies. So really not well established as a sleep aid. But I'd be curious to hear other people's thoughts. And finishing with some resources. So Canadian Sleep Society has some great info, both for clinicians and patients. The wellhealth.ca, so the tools produced by the family doctors in Canada have some great tools for clinicians, and they have a management of chronic insomnia tool. The Canadian Medication Appropriateness and Deprescribing Network also has some great tools and some guidance about deprescribing and some good patient manuals, as does the CCSMH, as I mentioned. Dr. David Gardner is a pharmacist out in Dalhousie and has created a website, mysleepwell.ca, that's just fantastic and has good information on both sleeping pills and CBTI for patients and clinicians. And a few others. If you want to learn a bit more, practice CBTI, the manual that I use, Cognitive Behavior Treatment of Insomnia by Perlis. There's also a good patient workbook, albeit harder in dementia, but the insomnia workbook. And there's a few apps for people that may have some help or be able to work through it. Sleepio at a cost and CBTI Coach is for free. It's a free app. And that was it. I'll stop sharing.